Hi, Chris Cox again, thoracic radiologist at Creighton University, and I'm going to be walking you through basics of pleural disease. This will be focusing on CT with some mention of radiograph imaging. So basically, when you are assessing the pleura, there really shouldn't be anything between the ribs and the lung. So you're looking for any type of fluid or soft tissue between the ribs and the lungs. You should remember that the costophrenic recess goes all the way to the inferiormost ribs. So anywhere you have ribs, you've got pleura. And then finally, you should remember that along the mediastinum, you also have the visceral and parietal pleura. Usually you'll have a thin fat plane between whatever the mediastinal structure is and the adjacent pleura. But you may have some structures like the descending aorta that immediately abut the lung and may even have a little bit of atelectasis next to it. So different manifestations of pleural disease that we'll be talking about include pleural fluid, empyema, pleural thickening, pleural calcifications, and pleural nodules and masses. So this is the only radiograph I'm going to show, as you will have already gone through that content with the aquifer lectures. But here I do just want to reiterate the dependent pleural fluid distribution on an upright chest radiograph where you develop the meniscus sign. But on a CT, the posterior pleural space is the dependent portion. So on this CT, we show pleural fluid along the bilateral lower lobes, consistent with a dependent pleural effusion. The fluid can be different densities. So in a simple pleural effusion, you expect that density to be around the Hounsfield level of 0, which would be water density, but it could be higher or lower in density depending on what that fluid is. So here in this example, I'm showing an hemothorax where we've got actually a hematocrit level of layering high density within the collection, indicating that this is a hemothorax. In a chylothorax, you may have fat density, which will be lower than the expected density of typical water, and that could be secondary to a lymphatic obstruction issue or a thoracic duct injury. In an empyema, an infection has been introduced into the pleural space, and in that reaction you get a thickening of the pleura. So in this example of an empyema, we have thickened visceral and parietal pleura, also known as the split pleura sign. This is also a contrast-enhanced study, making it a little easier for us to appreciate the thickened pleura. Also, the distribution of the fluid in the pleural space is not entirely dependent, as it courses along the lateral aspect of the lung. So non-dependent fluid, as well as fluid collections that do not have a typical configuration of the peripheral pleura, but begin to form more ovoid or loculated collections that taper towards the edges. This infection also happens to have a gas-forming component, and therefore we have both air and fluid within this loculated collection, which is characteristic of an empyema. In some cases, you will have thickening of the pleura without fluid. So that can be in the setting of, say, a chronic pleural inflammation that has thickened the pleura up. But also you could have malignancies that could produce this thickened pleural appearance. Or it may be iatrogenic. For instance, someone who's had recurrent effusions or pneumothoraces that have then been treated with an irritant such as talc to cause a chronic reaction that tacks the parietal and visceral pleura together to decrease the rate of pleural effusion or pneumothorax. Again, thinking about assessing whether or not there's pleural disease, if we look at the dark lung and then we think about where the ribs are, and in between we have this very bright line. That line is more dense than the bone and about as dense as the calcified pleural plaque. So this is consistent with bilateral pleural calcifications, which is almost pathognomonic for asbestos-related pleural changes, which this patient has. There are other causes of pleural calcifications, although they tend to be unilateral, such as an old hemothorax or prior tuberculous empyema. There are also malignancies that can calcify and be either unilateral or bilateral. But this very smooth, bilateral, even distribution is very classic for asbestos-related pleural changes. And then finally, recognizing pleural nodules and masses. So here again, this is a contrast-enhanced study where we've got a pleural effusion, but then you have multiple nodular masses and nodules in the distribution of the pleura in this patient with metastatic disease. We also see profound thickening along the right paratracheal stripe on the coronal images. So this is malignancy. And that's all we have for basics of assessing pleural disease on CT imaging. Thank you.